Part A. Extract 1. Questions 1 to 12. You hear an oncologist talking to a patient called Mihiraa. You now have 30 seconds to look at the notes.
Good morning, Mihiraa. I'm Dr. Simon Lee. How can I assist you today?
Good morning, doctor. I've been having some troubling symptoms lately, and I'm getting really worried. It started a few months ago with some mild back pain, but now it's gotten worse. The pain is more intense, especially at night, and it's really affecting my sleep. I also feel like there's some swelling around the area, and I've noticed that I sometimes get numbness in my legs. I'm just really concerned because it doesn't seem to be getting any better, no matter what I try.
I'm sorry to hear that you've been going through this, Mihiraa. Could you tell me more about the pain?
It's a deep, throbbing pain, mostly in the lower back. It's hard to describe, but it feels almost like a pressure, and it doesn't really go away with rest. I tried taking some over-the-counter painkillers like ibuprofen and acetaminophen, but they haven't helped much. I've also been applying heat packs, which offer some relief, but the pain always comes back.
It sounds quite uncomfortable. Have you tried any other treatments or remedies?
Yes, I've also been to a physiotherapist who gave me some exercises to strengthen my back muscles, but honestly, it hasn't made a big difference. I was also prescribed some muscle relaxants by my general practitioner. I think it was called cyclobenzaprine, but it didn't help with the pain either.
I see. Let's go over your medical history. Have you had any other medical conditions or surgeries in the past? Are there any other medications you've been taking?
Well, I've always been fairly healthy. No major surgeries or anything. About 2 years ago, I had some issues with anemia and was on iron supplements for about 6 months, but that's it. As for medications, besides the painkillers I mentioned, I've been taking a daily multivitamin, but nothing else.
And how about your family history? Any history of chronic illnesses, bone disorders, or cancers in your family?
My mother had osteoporosis, but it wasn't diagnosed until she was in her 60s. My father had high blood pressure and was on medication for that, but no history of cancer or anything like that in the family.
Thank you for sharing that, Mihiraa. Let's proceed with a physical examination to check your vital signs and assess the affected area. Your blood pressure is 120/80 mmHg, heart rate is 75 beats per minute, respiratory rate is 16 breaths per minute, and your temperature is 98.6 degrees Fahrenheit. Let me take a closer look at your back. I can feel some localized swelling here, and I notice tenderness when I press on this area. Does this feel like the pain you've been experiencing?
Yes, that's exactly where it hurts the most.
Based on what you've described and the physical examination, I suspect that you might have a condition called osteoblastoma. It's a rare, benign bone tumor, but it can cause significant discomfort and needs to be managed properly.
A tumor? That sounds scary. What does that mean for me?
I understand this might be alarming, Mihiraa. They can cause the symptoms you've been experiencing, like pain and swelling, particularly in the spine, but these are non-cancerous. The good news is that we have treatment options. First, I'd recommend imaging studies, such as an MRI or CT scan, to confirm the diagnosis. If it's confirmed, treatment might involve surgery to remove the tumor.
Thank you, doctor.
Extract 2. Questions 13 to 24. You hear a pulmonologist talking to a patient called Mihiraa. You now have 30 seconds to look at the notes.
Good morning, Mihiraa. I'm Dr. Kevin Manson, a pulmonologist. What brings you and your son to see me today?
Good morning, doctor. I'm really worried about my son Alan. He's been having persistent symptoms for a while now. He's always coughing, and it's a really thick, mucousy cough. He also seems to have trouble breathing sometimes, especially when he's trying to be active, like playing outside. Recently, he's been complaining about stomach pain, and his stools are very greasy. He's losing weight too, which really scares me.
I can understand why you're concerned. Can you describe a bit more about how Alan is feeling and how these issues are affecting him?
Alan is only 6 years old, but he's already so exhausted all the time. He used to be so active and playful, but now he's easily tired. I've noticed that he's not growing as well as other kids his age. His appetite isn't great, and even when he eats, it's like his body isn't absorbing the nutrients properly. It's heartbreaking to see him struggle like this.
It sounds like Alan is dealing with some significant challenges. Mihiraa, the symptoms you've described, especially the persistent cough, mucus production, difficulty breathing, and digestive issues, could be indicative of an underlying condition. Have you noticed any other symptoms, such as sinus infections, or has he been more prone to lung infections?
Yes, now that you mention it, Alan does seem to catch colds more frequently than other kids. And when he does, it takes him much longer to recover. He's had a couple of chest infections already this year. We've been to the doctor multiple times, but the antibiotics don't seem to help much.
Thank you for sharing all of this, Mihiraa. Given Alan's symptoms and the recurring nature of his infections, I suspect that he might have a condition called cystic fibrosis, which is a genetic disorder that affects the lungs, digestive system, and other organs by producing thick and sticky mucus that can block airways and lead to infections.
Oh my. I've heard of it, but I didn't realize it could be this serious.
Is there a history of the condition or any similar conditions in your family?
Well, my sister's son has asthma, and my mother had chronic bronchitis, but no one has ever mentioned this in our family.
Okay, it's inherited when a child receives two faulty genes, one from each parent. Even if there's no known history, it can still appear if both parents carry the gene. To confirm this diagnosis, I'd recommend we start with a few tests. The primary test is a sweat test, which measures the amount of salt in the sweat. High level of salt is an indication. We may also consider a genetic test to look for mutations in the CFTR gene, which is responsible for the condition.
How soon can we do these tests, and what will they involve?
We can schedule the test as soon as possible. It's a simple and non-invasive procedure. Mihiraa, the genetic test will involve a blood sample, which will be sent to a lab for analysis. Once we have the results, we can discuss them in detail. If the tests confirm the condition, treatment will be crucial to manage the symptoms and improve Alan's quality of life. Treatment usually includes daily chest physiotherapy to help clear mucus from the lungs, medications to reduce mucus production and treat lung infections, and enzyme supplements to aid digestion.
How long will Alan need to be on treatment, and what are the risks?
This is a lifelong condition, so treatment will be ongoing. The goal is to manage symptoms and prevent complications. The medications and therapies we use are generally safe, but like all treatments, they come with some risks. For example, the enzymes might cause mild digestive side effects, and some of the antibiotics used to treat infections could lead to antibiotic resistance over time. The most important thing is to stay vigilant and keep up with regular checkups. With the right care, many children with the condition grow up to lead full and active lives.
Thank you, Dr. Manson.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. You'll have time to read each question before you listen. Now look at question 25. You hear a doctor called Mihiraa talking to colleagues. Now read the question.
Team, I'm excited to introduce our new AI-powered chatbot, MediAssist. This innovative tool will streamline communication between departments and improve efficiency within our hospital.
That sounds interesting, Dr. Mihiraa. How will MediAssist work?
MediAssist will be accessible through a dedicated platform. You can use it to send and receive messages, request information, and even schedule appointments. It's designed to provide quick and accurate responses to your queries.
Will MediAssist replace human interaction?
No, MediAssist is intended to supplement human interaction, not replace it. For complex or sensitive matters, direct communication with colleagues remains essential. However, MediAssist can handle routine tasks and provide immediate assistance.
Are there any privacy concerns associated with using a chatbot, Dr. Mihiraa?
We have implemented robust security measures to protect patient data. MediAssist will only have access to information that is necessary for its functions. Your privacy remains our top priority.
Now look at question 26. You hear an occupational therapist called Mihiraa talking to a nurse. Now read the question.
Nurse Paul, I'm concerned about Mr. George's comfort while in bed. We need to ensure he has the most appropriate type of bed to support his needs.
That's a good point, Mihiraa. I believe he's currently using a standard hospital bed. Is there a more suitable option?
Depending on his specific needs, a specialized bed might be beneficial. For example, if he has difficulty getting in and out of bed, a low-profile bed or a bed with adjustable height might be helpful.
He does have limited mobility. A low-profile bed might be a good option. What about pressure ulcers? Should we consider a pressure-relieving mattress?
Absolutely. Pressure ulcers are a significant concern, especially for immobile patients. A pressure-relieving mattress can help prevent skin breakdown and promote healing.
Are there any other types of beds we should consider, Mihiraa?
If Mr. George has specific needs, such as increased support for his back or hips, we might explore specialty beds with built-in features. It's important to assess his individual needs and select the bed that best meets his requirements.
Now look at question 27. You hear a physiotherapist called Mihiraa talking to a patient. Now read the question.
Mr. Paul, given your persistent back pain, I think it would be beneficial to schedule an MRI scan to assess the underlying cause.
An MRI. Mihiraa, I've heard they can be uncomfortable.
It's understandable to feel anxious about the procedure. However, MRI scans are generally safe and painless. The only discomfort you might experience is from lying still for an extended period.
Are there any specific preparations I need to make for the MRI?
Yes, there are a few things to keep in mind. You'll need to remove any metal objects, such as jewelry or piercings. You may also need to change into a hospital gown.
Well, Mihiraa, I have a pacemaker. Will that be a problem?
Yes, the strong magnetic field in an MRI can interfere with certain medical devices, including pacemakers. We'll need to consult with your cardiologist to determine if an MRI is safe for you.
Now look at question 28. You hear a dentist called Mihiraa talking to a parent. Now read the question.
Mr. and Mrs. Paul, I'm pleased to discuss your son, Ryan's, upcoming dental procedure. We've determined that a dental cap, also known as a crown, is necessary to protect his decayed tooth.
We understand, Mihiraa. What exactly is a dental cap?
A dental cap is a custom-made covering that fits over a damaged or weakened tooth. It helps restore the tooth's function and appearance.
Will the procedure be painful for Ryan?
We'll ensure his comfort throughout the procedure. We'll use local anesthesia to numb the area around the tooth. There might be some discomfort after the procedure, but it should subside within a few days.
How long will the procedure take?
The procedure typically takes about an hour, depending on the complexity of the case.
Mihiraa, will Ryan need to avoid certain foods or activities after the procedure?
Yes, it's important to follow post-procedure care instructions. He'll need to avoid hard, chewy, or sticky foods for a few days. He should also refrain from strenuous activities that could dislodge the cap.
Now look at question 29. You hear a doctor called Mihiraa talking to a nurse. Now read the question.
Nurse Paul, have you reviewed Mr. George's recent chest X-ray?
Yes, Dr. Mihiraa. There seems to be some abnormal shadowing in the right lung.
That's concerning. Could you describe the location and appearance of the shadowing?
It's a well-defined, round opacity in the upper lobe of the right lung.
A round opacity could indicate several possibilities, including pneumonia, a tumor, or a pulmonary embolism. We'll need to conduct further tests to determine the exact cause.
Should we order a CT scan or a lung ultrasound?
A CT scan would provide more detailed images and help us differentiate between the possible causes. We can also consider a lung ultrasound to assess for pleural effusion or other abnormalities.
I'll schedule the necessary tests, Dr. Mihiraa, and inform Mr. George about the need for further evaluation.
It's important to monitor his symptoms closely and be prepared to adjust treatment as needed.
Now look at question 30. You hear a nurse in charge called Mihiraa talking to colleague. Now read the question.
Team, I'm excited to announce that we'll be implementing a 4-shift pattern in the ward starting next month. This new schedule aims to improve staff morale, reduce burnout, and enhance patient care.
I'm curious to know how this new pattern will work. Mihiraa, will it involve longer shifts or fewer days off?
The 4-shift pattern will involve working fewer days per week, but with slightly longer shifts. This will provide staff with more time for rest and personal commitments.
I'm concerned about the impact on patient care. Won't longer shifts lead to fatigue and reduced alertness?
We've carefully considered this. We'll implement strategies to manage fatigue, such as scheduled breaks and opportunities for rest during shifts. Additionally, we'll ensure adequate staffing to prevent excessive workloads.
Mihiraa, will this new pattern affect our existing shift preferences or seniority?
We'll prioritize the needs of our staff and accommodate their preferences as much as possible. However, there may be some adjustments required to ensure a balanced distribution of shifts.
That is the end of Part B. Now look at Part C.
Part C. Extract 1. Questions 31 to 36. You hear an endocrinologist, Dr. Haiden Zhou, talking about the unforgettable journey in his career. You now have 90 seconds to read questions 31 to 36. Good evening, everyone. I'm Dr. Haiden Zhou, an endocrinologist with a passion for uncovering the mysteries of rare diseases. Today, I want to share the remarkable story of a patient who left an indelible mark on my career, Mihiraa. This case not only challenged my medical knowledge, but also tested my ability to make critical decisions under pressure, collaborate with a multidisciplinary team, and ultimately support a patient facing extraordinary circumstances. Mihiraa's case is etched in my memory for several reasons. Firstly, it was not merely the rarity of her condition, but the complexity and the way it manifested that made it unforgettable. Mihiraa was a 32-year-old woman presenting with symptoms that at first glance seemed contradictory: hyperglycemia, yet unexplained weight loss, thyroid dysfunction, but no clear signs of Graves' disease, and episodes of severe hypertension that did not respond to conventional treatment. Her symptoms were a baffling puzzle, and every test we ran provided pieces that didn't quite fit together, leaving us with more questions than answers. Moreover, beyond the medical conundrum, it was Mihiraa's determination and trust in me as her physician that made her case stand out. She was aware of the risks and the uncertainty that surrounded her condition, yet she faced each day with courage. This deep connection and the responsibility it carried made me push the boundaries of my knowledge and expertise. Her condition required not just a diagnosis, but a deeper understanding of the interplay between various endocrine functions, which I had never encountered before in such an intricate manner. The most challenging moment in Mihiraa's case was when she suddenly deteriorated. Her blood pressure spiked to life-threatening levels, and despite our best efforts with standard interventions, nothing seemed to stabilize her condition. At this critical juncture, we faced a decision that could alter the course of her treatment and her life. We had two options: initiate an aggressive intervention with experimental treatments, or take a step back and reassess, risking the possibility of losing precious time. After an intense consultation with my colleagues and a deep reflection on Mihiraa's history and test results, I opted for a third, unconventional approach, one that straddled both paths. I decided to start a targeted therapy aimed at the adrenal glands, suspecting a rare form of adrenal tumor that was producing excess catecholamines, despite the lack of conclusive imaging results. This decision was based on a combination of clinical intuition, emerging research, and a nuanced understanding of endocrine disorders. It was a gamble, one that could either lead to a breakthrough or further complicate an already dire situation. Supporting Mihiraa through this ordeal was not just about administering the right treatment. It was about providing holistic care, addressing the psychological impact of living with an unpredictable and poorly understood disease, and the emotional strain of an uncertain prognosis. I made it a point to ensure that Mihiraa was informed and involved in every step of her treatment, fostering a partnership rather than a traditional doctor-patient relationship. Beyond the medical care, I coordinated with a psychologist specializing in chronic illness to help Mihiraa navigate the mental health challenges that accompanied her physical symptoms. I also engaged a nutritionist to tailor a diet that would support her fluctuating metabolic needs. Regular follow-ups, both in person and through telemedicine, were scheduled to monitor her progress and make adjustments as necessary. My plan was to remain adaptive, knowing that her condition could change at any moment, requiring immediate and informed responses. The complexity of Mihiraa's condition necessitated a multidisciplinary approach. From the very beginning, I worked closely with a team that included an oncologist, cardiologist, nephrologist, and radiologist. The coordination was not just about sharing information, but about integrating our different perspectives to form a cohesive treatment strategy. Regular multidisciplinary meetings were held to discuss Mihiraa's progress and adapt our approach as new information came to light. Each specialist contributed insights from their field, whether it was the oncologist's input on the potential malignancy of the adrenal mass or the cardiologist's advice on managing her refractory hypertension. My role was to synthesize this information, aligning it with the endocrine aspects of her disease to ensure a balanced and comprehensive treatment plan. The outcome of our collective efforts was nothing short of remarkable. The targeted therapy began to take effect, and Mihiraa's blood pressure gradually stabilized. Further testing confirmed the presence of a rare pheochromocytoma, a tumor of the adrenal glands that was responsible for her symptoms. With this diagnosis, we could refine her treatment plan, including a surgical approach to remove the tumor. Mihiraa's recovery was a slow and cautious process, but the results were encouraging. Her blood sugar levels normalized, her thyroid function began to regulate, and the hypertensive episodes became less frequent. The most gratifying moment came when she was finally able to leave the hospital, not cured, but significantly improved, with a clear path forward for her long-term care. Mihiraa's case has become a cornerstone of my career, a reminder of the importance of persistence, creativity, and collaboration in medicine. It reinforced my belief that medicine is as much an art as it is a science, requiring not just knowledge but intuition and empathy. The experience pushed me to delve deeper into the endocrine system's intricacies and has inspired me to pursue further research into rare adrenal disorders. This case also taught me the value of a multidisciplinary approach, highlighting that no single doctor can have all the answers, especially when dealing with complex, rare diseases. Mihiraa's journey reminds me daily of why I chose this profession, to make a tangible difference in the lives of patients, no matter how challenging the path might be.
Now look at Extract 2. You now have 90 seconds to read questions 37 to 42. You hear the conversation between a microbiologist, Dr. Mihiraa, and an interviewer.
Dr. Mihiraa, thank you for joining us today. To begin, could you explain the main focus of your current research on cystic kidney disease?
Thank you for having me. My research primarily focuses on understanding the genetic and molecular mechanisms that underlie cystic kidney disease, specifically autosomal dominant polycystic kidney disease, ADPKD. ADPKD is the most common form of cystic kidney disease and is characterized by the growth of numerous fluid-filled cysts in the kidneys, which can lead to renal failure. My study aims to identify the key genetic mutations responsible for the disease and to explore how these mutations disrupt cellular functions in the kidney. We are particularly interested in the signaling pathways that regulate cell proliferation and apoptosis, as these processes are crucial in the formation and expansion of cysts.
That sounds fascinating. How did your study initially get started, Dr. Mihiraa? What were the first steps in your research process?
The study began with an extensive review of existing literature and previous research to identify gaps in our current understanding of ADPKD. We then conducted a large-scale genetic analysis of patients diagnosed with the disease, utilizing both whole exome sequencing and RNA sequencing to uncover novel mutations that had not been previously linked to cystic kidney disease. Additionally, we established a biobank of kidney tissue samples from patients at various stages of the disease, which has been invaluable in studying the progression of cyst formation. Our team also developed several in vitro and in vivo models to mimic the disease, allowing us to investigate how specific genetic mutations contribute to the pathogenesis of ADPKD.
With such a complex condition, Dr. Mihiraa, what have been the main challenges you've faced during your research?
One of the biggest challenges has been the genetic heterogeneity of ADPKD. The disease can be caused by mutations in different genes, each potentially leading to different clinical outcomes. This variability complicates the identification of common pathways and mechanisms that could be targeted for treatment. Moreover, the slow progression of cystic kidney disease makes it difficult to assess the long-term efficacy of potential therapies in preclinical models. Another significant challenge has been the limited availability of patient-derived kidney cells, which are essential for studying disease mechanisms in a context that closely resembles human pathology. To overcome this, we have been collaborating with multiple institutions to share resources and data, which has helped to mitigate some of these challenges.
Speaking of advancements, Dr. Mihiraa, what are the latest developments in your study?
Recently, we have made significant progress in identifying a novel signaling pathway that appears to be critically involved in cyst formation and growth. This pathway, which we have termed the PKD signaling cascade, involves a series of interactions between proteins that regulate cellular proliferation and fluid secretion within the cysts. Our findings suggest that this pathway could be a promising therapeutic target. Additionally, we have developed a new 3D organoid model of ADPKD using patient-derived stem cells. This model closely mimics the kidney environment and has already provided valuable insights into how cysts form and expand. We are currently testing a series of small molecule inhibitors on these organoids to evaluate their potential as therapeutic agents.
That's impressive, Dr. Mihiraa. What outcomes do you expect from this research in the long term?
Ultimately, we hope that our research will lead to the development of new, more effective treatments for ADPKD. By targeting the newly discovered PKD signaling cascade, we aim to develop therapies that can slow down or even halt the progression of cyst formation, thereby preserving kidney function in patients for a longer period. Additionally, our work with 3D organoids may pave the way for personalized medicine approaches, where treatments can be tailored to the specific genetic mutations present in an individual patient. In the long term, our goal is to significantly reduce the burden of cystic kidney disease and improve the quality of life for those affected by it.
Finally, what impact do you foresee this study having on the broader field of nephrology, Dr. Mihiraa?
This study has the potential to greatly impact the field of nephrology by providing a deeper understanding of the molecular mechanisms driving cystic kidney disease, which could be applicable to other forms of renal disease as well. The identification of the PKD signaling cascade could lead to the discovery of similar pathways involved in other kidney conditions, potentially broadening the scope of therapeutic targets. Furthermore, our development of 3D organoid models could revolutionize how kidney diseases are studied, offering a more accurate and scalable system for drug testing. The methodologies and findings from our research could thus influence both clinical practice and future research in nephrology, particularly in the area of genetic kidney diseases.
That is the end of your OET listening test. Now check the answers.